Kallakurichi.
Thank you, sir.
யாருமே தமிழில் காலைல வந்து பேசவில்லைன்னு நினைக்கிறேன். கள்ளக்குறிச்சிக்கு வந்திருக்கும் எனது நண்பர்களுக்கு டெலிகேட்ஸ்க்கு மனமார்ந்த வரவேற்பு. இதை சிறப்பாக செய்து கொண்டிருக்கும் கள்ளக்குறிச்சி API, அதை முன்னின்று செய்யும் எனது நண்பர் ரவிச்சந்திரன் அவர்களை பாராட்டி, இந்த டாப்பிக்கில் காலையிலேருந்து நம்ம போயிட்டு இருந்தால் கூட the very interesting topic, evergreen topic, wherever we feel after cardiology, next is neurology. Always we say stroke. Everybody, whether illiterate or literate or eminent or ineminent, everybody talks about stroke. But what is stroke? Always evergreen stroke. What is new in stroke? Our friend Dr. APPAND RAJ is going to speak. He is a very eminent and he delivered speeches in more than 150 webinars, over 100 CMEs, 50 state conferences and 10 national conferences, including Epicon 2023 and 24. Well-known figure of our Tamil Nadu API. Curriculum committee member since 2017, contributed chapters to API update 2023 and 24. Executive committee member of TN API, honorary general secretary of API Chengalpattu, member of medical education unit since 2015. Completed advanced course in medical education at CMC Vellore, active member of API, TN API, HSC, IC, EC, CM, RSD awards, FSCP award at Epicon, best ASN award. This சொல்றதுக்கே காமனா ரொம்ப இருக்கு. Very welcome, sir. We need your expression and expert.
Thanks, the chairperson, for the wonderful introduction. At the start, I want to extend my wishes as well as thanks to Dr. Ravichandran and the team for the excellent conference that they are making in Kallakurichi. So the topic given to me is acute ischemic stroke, timely intervention to reduce the neurological damage. See, we all know time is very important. Okay. So stroke, we all know stroke can be ischemic or it could be hemorrhagic, and we know among the ischemic stroke, it could be thrombosis, it could be embolism. When it is thrombosis, it can be because of the large vessel or small vessel, or it could be when it is embolism, it can be because of cardiac, or it could be from the artery. So stroke is whether it is an Indian disease. Yeah, definitely we are getting stroke at almost 10 years before other countries. So other the Western counterparts. And when you see among the population who are having mortality when they get stroke, it is more with the South Asian population when compared to the Western counterparts. And we have more commonly acute ischemic stroke. Ischemic stroke is very common in India, and we know the most of the risk factors for it. So why time is very important? Time is brain. So for every second you are losing some amount of neurons, some amount of synapses, myelinated fibers. For every second you are losing almost 32,000 neurons, and almost you are getting age by 8.7 hours. And when a particular stroke, one stroke itself can make you age by 36 years. And you can see in 1 minute, 2 million brain cells die every minute, and 14 billion synapses are lost, and 7 myelinated fibers are lost. So the goals of acute stroke management. So first is screen the patients rapidly, identify those who are eligible for thrombolysis, because thrombolysis is time bound. Thrombolysis is the only approved treatment of choice because it prevents infarct progression as well as recurrence, and optimum control of blood pressure, sugar, aspiration, pneumonia and DVT prophylaxis, and start physiotherapy yearly. So intravenous thrombolysis. So it can be done for all eligible patients. First 4.5 hours is the golden period, and the agent is tissue plasminogen activator. The most commonly used is Altiplase, 0.9 milligram per kilogram body weight, and the maximum dose is 90 milligram. First 10% of the dose is given as a IV bolus over 1 minute, then remaining 90% should be given in next 1 hour, and we have to continuously monitor the BP and cardiac monitoring. The inclusion criteria is duration less than 4.5 hours after the onset of symptoms. There should not be any bleed in the CT, and symptoms should be because of the stroke, stroke mimics has to be excluded. That is very important, and age should be greater than or equal to 18 years, a significant neurological deficit, which can result in long-term disability. So this should be the inclusion criteria. And stroke mimics, those mimic like stroke, but they are not actually strokes. That means, irukku ana illa. So we have migraine, seizures, toxic metabolic processes, and lot of conversion reaction, etc. And we should not miss stroke chameleons. Okay, so it will have very subtle symptoms, but patient can present with typical stroke, and they have more mortality than even the normal presentation stroke people because of its late diagnosis. So we should be very careful about the stroke chameleons. So we have bilateral thalamic strokes, limb shaking, TIA, cortical strokes, etc. And this means illa ana irukku. So that we have to be very, very important to note down. So the exclusion criteria. So there are a lot of things from bleeding diathesis to lot of things, but we have time is one important certain. So more than 4.0 hours is not there. So presence of blood on brain scan, symptoms have completely resolved. That is TIA. Very minor symptoms, NIHSS score of less than 4. And similarly, NIHSS score greater than 24 is also not in criteria to give the thrombolysis. In fact, occupying more than half of the hemisphere, and BP greater than 180 and diastolic BP greater than 105, even after treatment with labetalol. So we have the NIHSS scale that we can refer. It take into consideration consciousness, commands and visual fields, facial palsy, arm, leg, ataxia, etc. So, and lesser the score, better the prognosis. Very less score, no need for thrombolysis. So who can thrombolysis? So neurologist, internist, and it can be emergency physicians. A study has been shown, if we are allowing the emergency residents or emergency physicians to do that, so the time to thrombolysis is reduced to 28 minutes from 54 minutes. So though it can be effective till 4.5 hours, as early as possible is very important because time is brain. So the time goal for thrombolytic therapy, so we have to, within minute we have to find out it is a stroke. Less than 10 minutes, we have to do the initial evaluation. Within 15 minutes, stroke team has to be informed. Within 25 minutes, CT should be planned and should be taken. And within 45 minutes, everything should be done. And within 60 minutes, and this thrombolysis has to be done. And when it is very good team, good effort, definitely it can be done even in 30 minutes. So thrombolysis with the tenecteplase. So we have alteplase, so we have tenecteplase. It's a good alternative because it can be given as a bolus. Dose is 0.25 milligram per kilogram and the maximum dose is 25 milligram. Approved for stroke thrombolysis within 3 to 4.5 hours. Yearly neurological outcome is better when compared with that of the alteplase. And outcome at 90 days as well as the complications are similar to that of the alteplase. But the cost of tenecteplase is less than the alteplase. So the fibrin specificity and the thrombolytic potency are better with the tenecteplase, and even the studies have shown it is better at the short-term mortality and morbidity. And complications. So definitely you will be expecting complications after IV thrombolysis, symptomatic intracerebral hemorrhage, asymptomatic intracerebral hemorrhage, systemic bleeding and angioedema. So the HAT score will give you the criteria how much bleeding can happen. So you take into consideration your diabetic status and the previous NIHSS score. Whenever the HHS score is more, definitely you are going to have the higher risk of bleeding and presence of involvement of territory. When there is no hypodensity in the initial scan, it is going to have a good prognosis, less amount of bleeding, and when it is more than 1/3, we are going to have a more chances of bleeding. And the next important treatment is mechanical thrombectomy, endovascular interventions. So those patients who are eligible for intravenous thrombolysis, okay, they should be considered for endovascular treatments even though they are undergone the thrombolysis. So the first is modified Ranskin score of 0 to 1. So we all know about the modified Ranskin score, which from no symptoms, only mild disability, no symptoms, no disability, and mild, moderate, severe, moderate to severe, severe, and sixth is death. So pre-stroke modified Rankin score of 0 to 1, and acute ischemic stroke receiving within 4.5 hours, and whenever there is a internal carotid artery occlusion or proximal MCA occlusion. So age greater than 18 years or more, NIHSS score greater than 6, and aspect score. In aspect score, we will be dividing the brain into 10 parts, and each part, whenever there is a ischemia, 1 point will be reduced. Okay, so procedures should be done as early as possible because they can have the maximum effect, but it should be done within 6 hours. Benefits of endovascular therapy beyond 6 hours is controversial, and those who are having contraindications for thrombolysis also can be subjected to the mechanical thrombectomy. So endovascular therapy can be extended to MCA territories, M2, M3 portions also, ACA portions also, and PCA if procedure can be started within 6 hours. May be reasonable for children below 18 years, and technical goal should be the TC grade 2B to 3 angiographic results to maximize the benefits. So there will be a stent retriever which grasps the clot. The stent and clot will be pulled towards the catheter, and the vacuum catheter holds the clot, and clot, stent and catheter all will be pulled out. This is what that has been done in the mechanical thrombectomy, and even when this is failing because of the adherent, we can go for the intra-arterial thrombolysis. So this is the protocol. So when it is less than 4.5, do a patient with the thrombolysis, intravenous thrombolysis. So if still it is within 6 hours, if it is anterior circulation, definitely when there is a large artery occlusion, you can go for the mechanical thrombectomy. So even if it is greater than 6 to 24 hours, we can go with the modified Dawn's trial or diffuse 3 trial. Whenever there is a mismatch between the findings and the presentation, we can go for the thrombolysis. As already told, posterior circulation stroke, there could be mechanical thrombectomy within 6 hours. So whenever there is no causative large artery occlusion, standard evolution of care. So next, antiplatelets. All patients should be given antiplatelets, aspirin or clopidogrel within 24 hours. Whenever there is a thrombolysis, we can defer it after 24 hours. So anticoagulation, dual anticoagulation is preferred for next 21 days. And after that, it can be changed into one depending on the condition. So anticoagulants for ischemic stroke should be reserved only for atrial fibrillation, ventricular thrombus, and mechanical heart valve or treatment of venous thromboembolism. So Piracetam at the dose of 4.8 grams, that is 2,400 milligram twice daily, has found to be superior, and it has been supported by the studies, and it reduces the, improves the cerebral blood flow. And similarly, oral citicoline at the dose of 500 to 2,000 milligram per day has been found to be useful when the recovery is there, and 2,000 milligram has found to be the better dose, and citicoline has found to be better whenever the NIHSS score is less than 14, whenever the age is greater than 70, and those patients who have not been subjected to the thrombolysis. So supportive care, we have cardiac monitoring, adequate oxygenation, protection of the airway, treatment of hypertension, treatment of fever and hyperglycemia. Cardiac monitoring, as already told, target blood pressure should be 180/105. Whenever it is not thrombolyzed, we can keep slightly higher, 220/120. And airway and oxygenation has class 1 support evidence. And hyperglycemia, among the patients admitted with the stroke, almost 40 to 50% will be diabetic, whether they can be diagnosed at that time. So additional 20% of the people can have stress hyperglycemia. So in a total, 60 to 70% of the people will have hyperglycemia, and as per the ADA guidelines, so whenever there is a diabetic hyperglycemia, so we have to maintain the blood sugar between 140 to 180. So American Stroke Association guidelines is to maintain between 140 to 180, and it should not defer you from going for the thrombolysis. From 50 to 500 you can do the thrombolysis, but you can control the blood sugar. So stroke team should be a multidisciplinary. Immobilized patient should be started on low molecular weight heparin to prevent DVT. Concomitant medical illness should be treated. Temperature should be kept normal. Antipyretics can be used, and management of acute neurological complications. Whenever there is a raised ICP, we can use mannitol, mechanical ventilation or decompressive surgery. Malignant MCA infarction, decompression hemicraniectomy can be done. Larger cerebellar infarcts, posterior fossa decompression can be done. Acute hydrocephalus, external ventricular drain. So it's better to have the neurosurgical facilities in the management of acute ischemic stroke. Seizures can occur in 2 to 33%, and the treatment is in the similar way to the other seizure patients, non-stroke settings. So the key takeaways: IV thrombolysis is the best treatment for the acute ischemic stroke. Aspirin should be administered as early as possible. Paracetamol and ceticoline are effective and safe agents in several cases of acute stroke. Appropriate control of BP and sugars are needed. Maintain adequate airway, oxygenation and temperature. Prevent aspiration pneumonia and DVT. Recognize and treat acute neurological complications. Reperfusion is very potential to reverse the neurological impairment. It will reduce the penumbra region, and reperfusion offers the potential to reduce the extent of ischemic injury. So time is brain. Thank you.
Eminent diaphragmist in Tamil Nadu, sir. வாழ்த்துக்கள் சார். லாஸ்ட் மீட்டிங் நம்ம 2 பேர் மீட் பண்ணணும்னு நினைக்கிறேன் சார். சிஎம்பிஜி பற்றி ரொம்ப அழகாக சொன்னீங்க. எப்பவுமே கேட்குற ஒரே டவுட் தான் சார், டிஃபரன்ஸ் பிட்வீன் கேப்லரி குளுக்கோஸ் அண்ட் சிஎம்பிஜி குளுக்கோஸ்.
So it is 10 to 20% difference will be there. Capillary blood glucose, the glucometer measures capillary blood glucose, which is higher than the venous plasma, and interstitial glucose is lower than these levels. So the idea is it has to be maintained between the targets, that is 70 to 180, not the values. We need to maintain the blood sugar between 70 to 180. That should be the target for CG.
The molecule, I mean the thyroxine from one brand to another in pregnancy?
Sir. So actually, sir, though the thyroxine is same, the preservative differs. So what the manufacturers say is, it's better to stick with the same brand, and there is no anything to say against shifting, but the impurities and other things, like it's just like shifting one person from Fias to an Limjevi without any indication. So all are different. So they will have subtle differences, and also the stability also matters. If you look at certain brands, some of them are stable only for 6 months, some of them are stable up to 3 years. So as far as possible, we try to stick with the same brand, sir.
In clinical practice, we have witnessed